Welcome to Focus on Seniors, a television show sponsored by Helping Seniors of Brevard County, Florida. The show is designed to make you aware of senior issues, needs, and resources available to help us age in place and with dignity. This show will help you as you develop your own aging and care plan.
I'm Joe Steckler. Welcome to Focus on Seniors, the television arm of Helping Seniors of Brevard County, a show designed to provide you with information on how to develop your own aging and care plans. Our topic today is what skilled home health care can do for you. With me in the studio is Marco Bensimon, who is the physical therapist and rehabilitation director, and Nancy Deardorff, registered nurse and branch director for Gentiva Healthcare Homecare of Melbourne. You know, I'll get that right because I learned something today, folks. I've been for years referring to Nancy's services as skilled nursing care. Skilled nursing care is only a part of skilled home health care. I finally got it right.
Absolutely, yes.
I got it right. So I learned something, and we're going to talk about all aspects of skilled home health care today, and I hope you'll learn something that will help you. Well, what is skilled home health care? And you, since you are the branch director, I won't give you a promotion today. I'll call you the branch director.
Okay.
I don't have to do that. But what is what you do?
What is what we do? Well, in very lay terms, and the reason I put it this way is not because I don't give people credit, but because unless you've experienced home health, most people don't know it exists or what it's all about.
You're right.
Also, home health is a very umbrella term. It can mean a lot of different things to a lot of different people. So the way I break it down is basically there's two types of home health. There's home health that I call private duty home health. Private duty home health is primarily funded by people out of pocket and or some long-term insurance plans and some select insurance plans that have a home health benefit. Largely, private duty home health does not have a skilled component. Oftentimes it is home health aides or it is companions, people that go in to make someone a meal, help them shower, transport them to and from the doctor, get them groceries. That's not what we at Gentiva do. The second kind of home health is what we at Gentiva do, amongst other companies, right. And that is what we call skilled home health care services. Skilled home health care services is covered if a patient qualifies by Medicare for either people 65 years of age and older or those that qualify for Medicare based on disability. The major
and an insurance plan.
Yes, we also take insurance,
right.
Yes, absolutely. And actually, to be honest with you, sometimes we get private pay clients. But the difference between private duty home health and skilled home health is the fact that skilled home health, A, requires a prescription from a doctor. It requires the skill of either a nurse, a physical therapist, speech therapist, at times occupational therapy, and the patient has to have a disease or illness that can be treated in the home. Now let me clarify that as well because it can be rather complicated. The point of skilled home health care, to me, in simplified terms, is twofold. We either go in the home to treat a person who can recuperate and recover from those illnesses that you can recuperate and recover from. For instance, joint replacement surgery. You can recoup and recover from that. But more often why we go in is to treat those disease processes that don't go away. They don't recuperate or recover from it. Those chronic disease processes such as diabetes, heart failure, chronic obstructive pulmonary disease or emphysema. And then our point is to teach the patient, their family and caregivers, how do you manage that chronic disease process in the home, prevent hospitalization, and keep you as healthy as possible, as independent as possible, and in your home so that you can age in place. And that's basically what skilled home health care is all about.
Okay, now let me ask a question. What you just said, when you got emphysema, COPD, things like that, at what point, when does hospice enter this equation, and do you and hospice work together?
Yes and no. How we work together is that it's home health's responsibility to identify a patient who's perhaps entered a terminal state of their disease process and make appropriate referrals to hospice. The hospice Medicare benefit has many benefits that the home health benefit doesn't have. Bereavement care, certain respite care. Home health doesn't have that care. Okay. So we take that very seriously. We say, okay, if that patient is in a terminal state, and let me clarify, that doesn't mean death is upon the door. It takes usually a hospice physician to certify that that patient is terminally ill and is expected to pass away within 6 months, roughly.
Yes.
When we see that, and we see that the hospice benefit can benefit our patient more than home health, we make that referral. Okay? So that's how we work with hospice. You really don't have home health patients on board the same time with hospice and home health. Okay. We don't. All right, so it's not like, well, Gentiva would go in and then the hospice would go in. It's sort of one or the other, and it really just depends on that patient's specific needs.
Okay. Now, I'm sure that the viewers can understand what you're talking about right now, and you mentioned speech therapy and you mentioned therapist, but you also mentioned a thing called occupational therapy. Mm-hmm. What really is occupational therapy? What is it?
I'm going to defer to Marco on that. I have a great explanation, but being our rehab director, and he is in charge of our physical therapist and occupational therapist at Gentiva, I'm going to default to Marco to give you an explanation because I think the term occupational leads people down an incorrect.
It does me.
You think occupation, what you do for a living. So I'm going to default to Marco to explain what an occupational therapist actually does.
I want to know what occupational therapy is.
Absolutely. Occupational therapy it differs from physical therapy in many ways. Occupational therapy touches issues like, say, for example, activities of daily living. Okay, ADLs. What are ADLs? People dress themselves in the morning, right? People shower. People go to the bathroom, right? People go to the kitchen and use the utensils, cook. So occupational therapy usually hones into these issues, particularly in the home health care realm. That's where occupational therapy enters this equation. That's where occupational therapy is. There's also occupational therapy also touches issues that are pertaining to the use of the hands per se, more so than physical therapy. For some reason, that is the way things are separated. So that's pretty much what occupational therapy is.
Yeah, but wait a minute.
And in some cases, vision.
As well.
How to compensate for poor vision.
Under occupation?
Yes. Yes, well. They do much more than people think. Occupational therapy does not mean getting back to your occupation.
Yep.
It's much more than. Well, think about what our seniors have problems with that live alone, okay? Or
the dressing and all that.
Okay, they have problems. Maybe brushing their teeth, grooming, putting on makeup, putting on underwear and their clothing, getting in and out of the shower, buttoning buttons, zipping zippers, tying shoes, or even in the case of Velcroing those shoes. Making a meal, even if families prepare a meal ahead of time, it's still going to require that senior to go to the fridge, get that meal out, and perhaps put it in a microwave. Manipulate those buttons. Open a package. Make a cup of coffee.
Okay,
that's occupational therapy.
How long? Let's say you identify a need and for occupational therapy.
Yes.
The occupational therapist then goes in to teach the person how to do these functions. But what if they can't be taught how to do them? Then what happens?
You want to get that one or me?
I'm going to try.
Okay.
Occupational therapists and physical therapists work in tandem. You see, physical therapists usually are concerned with the gross motor skills, like, say, transferring an ambulation, right? And like Nancy was saying, occupational therapists work mostly with fine motor skills. And a lot of patients are maybe not quite there cognitively, right? Occupational therapy also works in those areas, okay? Helping to train the patient to get to the point where they can perform these skills. They don't have to be cognitively completely there, but they are trained to perform or to going back to performing those issues. So that's how occupational therapy works.
Well, so
Yeah, and I want to add on to that.
Okay, go ahead, because I still want to ask a couple questions.
Okay, with people with cognitive disabilities, with dementia, you know, and I know this is a subject near and dear to your heart, we can't write these people off. And I've heard many in healthcare write these people off and say, well, they can't be taught, they have Alzheimer's or dementia or cognitive issues. That's not true. Studies show a habit takes approximately 3 weeks to fall into. Okay? If you do something over and over and over again, it becomes a habit. Yes. If we can teach the cognitively impaired, the dementia patient, a new habit, it becomes rote. It becomes rote. Agree. In the case, to answer your original question, where a patient can't learn, then what occupational therapy, as well as physical therapy and nursing can do, is teach that caregiver or family methods to help that patient. So, we're talking about occupational therapy. We can teach that caregiver, here's how you want to get your loved one in and out of the shower. Yes. Here's what you do want to do. Here's what you don't want to do to maximize the safety of that patient and the safety of the caregiver.
When you have the other kind of home care, which is not skilled type home care, you have the worker bees that go in to help the person get in and out of the shower, to do the cooking, to do the cleaning, to make the beds.
There's no skill level taught. It's doing for.
Right.
It's doing for. I'll put your laundry in the dryer for you versus I'm going to show you how to put the laundry in the dryer and how to press those buttons. And you know, to the average viewer out there, it might seem rather simple, it might seem so elementary, but until you've had a parent that's aging that suddenly completely forgets how to use an answering machine to answer a message. Yeah. Now, many of us have experienced that. We call our parent, they don't answer the phone, a message is left, they don't know how to retrieve the message. They don't know how to press the buttons to heat up something so simple like a bowl of soup. Mm-hmm. Those little things that seem so inconsequential in our life day to day become enormous problems later in life when you have the senior that we're trying to keep at home and trying to keep them aging in place.
Okay, so the occupational therapist has a twofold function. They do their best to train the patient. If they can't train the patient, they train the caregiver in the home. And I understand that the purpose of occupational therapy in this case then is to train one or the other. Where the home health care aide comes in to help that patient if the caregiver can't do it. Well, the caregiver may know how to do it. They're not there to do it.
I think it's an adjunct to the way I look at home health aide services and nursing assistant services, whether it be for private duty or for, particularly in the case of skilled home health care, I look at the home health aide as an extension of nursing or therapy.
I agree.
Okay, so if occupational therapist says, this is what I'm teaching the patient and the caregiver, this is what I want them to do, then on days the home health aide goes out to help that patient get in the shower, that home health aide has already received instruction from the occupational therapist. This is what I want you to do. This is what I don't want you to do. For instance, those of us that are nurses and nursing assistants, we have an innate want to do for people. Mm-hmm. Let me do that for you. Therapists are taught different. Therapists are taught correctly. And the days of nursing and nursing assistants where we said in the hospital to the patient, roll over, I'll give you a nice back rub before you go to bed. Or let me give you your sponge bath. Those days are gone. We're in the state of financial affairs where it's very important to save money and it's very important for people to be invested in the home care. So instead of me doing for you, I'm going to show you how to do for yourself. Because no matter whether it's private duty, but particularly in skilled nursing care, it's not meant to be forever. There is an end point to it. So our goal on day one when we go out there is to say to the patient, we're here to help you, but we're also here to help you figure out what are you going to do when we're no longer here? Because we're only going to be here for a certain period of time. Yeah,
recently I was doing a show on hospice. My back was killing me. And the director for the Woodstock Hospice House was sitting in the audience watching her medical director and one of the other ladies there. And after the show I said, I said the same thing you did. In the old days, registered nurses were taught how to rub a back. And boy, I could have really used that today to help my back. She just laughed at me like you do.
Nurses don't have even time to do that.
I know, but you're ignoring me right now when I'm talking about rubbing my back. It's just like
I'll have your back right now if you want to, right here on the show.
Yeah, you got me. My wife says, Joe, people are going to back you in a corner when you kid them about something. She just did that. But maybe I'm real a little bit.
We could do a whole back rubbing show if you want.
That would be good.
Although I would suffice to say Marco would be better at it than me. Plus he's strong, right?
You know, I haven't even got into this stuff. How do people qualify for home skilled health nursing services? Is it generally after an operation?
No, not at all. Not at all. In fact, that's probably the least of our patients. Our patients come from the hospital after procedures. Our patients come from nursing homes after, say, they go to the hospital and then they go for a rehabilitation stay, the joint replacement patient. They go to a rehabilitation facility to get strengthening in that hip or knee. But then the beauty of the home is we help them rehab in their own home. What better place to rehab than in your own home? A gym is great. You have all this fancy equipment. You have tons of room at a rehab center. At home, the reality sets in. You have narrow hallways. You have furniture. You have throw rugs. You have obstacles. You're trying to negotiate that walker, okay? So to me, there's no better place to rehab than at home. But generally speaking, Medicare home health is primarily paid for by Medicare for people 65 and older. Now, we at Gentiva, we specialize in the care of seniors. There is a certain amount of insurances that do cover home health services. So we take Medicare, we take insurances, and basically the primary coverage criteria is a physician's prescription. Followed by the fact that the patient has to have difficulty leaving their home.
Yes.
Okay.
Difficulty leaving their home?
Difficulty leaving their home because Medicare created the home health benefit for the sole purposes of bringing health care to people that otherwise had trouble getting to health care because they didn't have a good ability to get outside of their home.
Yeah, and another thing, and you and I have talked about this before, but it's something that just bears repeating. So often, the long-term health care policy covers the provision of the type of services we're talking about today, and people that have the long-term health care policies don't realize it.
Correct, they don't. They think of it in terms of nursing home. But home health is a benefit of many long-term care policies.
And home adult day health care is another benefit. Mm-hmm. What other type things should our general public be aware of when we're talking about skilled home health care services, Nancy and Marco?
Speech therapy is one that jumps to mind as well. I mean, speech therapy is very important as well. A lot of people that after strokes, after CVAs, need the help of a speech therapist, and they qualify for the homebound status that Nancy just alluded to. It is a taxing effort for the patient to leave the home safely, and a lot of people that have CVAs, that's exactly what happens.
But it's also hard for the caregiver to get them out of the home too.
As well.
Another really, really important thing, I think, from a person that has had the skilled nursing services in home and having been in so many homes of seniors that have obstacle courses in the home.
Yes.
The skilled home health care service people, when you all go into a home, don't you sort of research the home to look for obstacles and things that could adversely affect that family and talk to them about it?
Part of our assessment is assessing the home for the safety of the patient. Many people, like you just said, have throw rugs, have like an obstacle course at home. And what we try to do is we try to come and suggest, tell them, listen, this is not going to be safe for this gentleman or for this lady. And we need to make sure that we want to get this patient accustomed again to their own environment, but we wanted to make it as safe as possible to avoid a fall, which would be disastrous, and to make sure that patient recovers in their home safely.
Can I bring something up? Sure. Marco and I work on reports every time a patient falls, even if we're not with them. They just tell us when one of our nurses or therapists goes out. We record that, and we try to record by record I mean document the circumstances surrounding that. You would not believe how many people fall as a result of two things I want to point out. There's multiple reasons for falls, we know. But one of them is trying to get to the telephone while it's ringing before it stops ringing. So caregivers, loved ones, families need to tell their people, take your time. If it's important, they'll call back. And or a portable phone.
Yeah.
And how many people experience a fall because of their own assistive device, such as a walker or a cane, that is designed to help them not fall, but because they don't use it correctly, they end up tripping over it.
Exactly.
It's amazing. I can't even tell you.
Exactly.
I use a cane, and I use the cane because I have a back problem which has affected my balance. And I realize how important it is to do everything I can to protect my own safety. And when you talk about the telephone, I have learned that there are so many calls come in now from organizations wanting donations, and especially now with the elections coming up, the people, I let the phone ring. And
Thank you.
Yeah, you should.
Thank you. If it's a family or loved one or friend, they'll call back. They'll ring and ring and ring and ring. And that's part of the problem is sometimes the ringers are set so low it kicks into the answering machine. It's just, you know, I mean, the generation that we take care of, which is 80 and above, are not used to answering machines from way back when. And they're used to, that phone rings, you got to get to it. And they rush to get to that phone. And that's not the way it has to be.
I can't rush anymore. I can't go that fast.
But a lot of people do, and they fall in the process.
I know.
It's a shame. Sometimes the call is to check on the person to say, are you okay? And they fall trying to get to that phone call.
But, you know, other people use the that telephone as a let it ring and use it as an answering machine to check out who's calling them. I've got some friends.
Nothing wrong with that.
Yeah, I've got some friends that always will let the phone ring, and you've got this.
They screen their calls.
And I'll say, okay, so and so, you can pick up the phone. I'm not going to go away till you pick it up.
Yeah.
And
do they pick up?
Yeah.
Okay.
Oh yeah, they're there.
You're a hard man to say no to, by the way.
Yeah, but 99% of the time they're there. But they screen their calls.
Absolutely.
And they just don't. But the skilled home health services, the safety aspect of it is something that we don't. And how, you know, I can remember when a lady from the Alzheimer's now, we had a lady call us and she wanted some help. So we decided we'd go to her house. She opened the door and we went, we visited her, and she had that button thing you're supposed to wear around your neck, safety thing. I said, where is that? And she was over there. It was on the
table. She was not wearing it.
On the end table. I said, well, that's not going to do you any good over there. I made her promise me she'd wear it. I went back 2 weeks later without telling her I was coming. I knocked on the door. She said, who is it? And I told her. She opened the door immediately. She had that thing hanging on her neck.
Great.
Sometimes, as we grow older, we need the encouragement of people saying, please do this, think about doing this thing, and that's so important. And I have become more understanding and appreciative of skilled home health services since I've used them 3 times myself. And it's not something that you have to fear. And on the other hand, and I would like for both of you to talk about this, you especially, Nancy, because you've heard me talk about elements of care so many times. I think that skilled home health services should be more publicized as an element of care in this step ladder as we go up, because the more things we can do in the home, it certainly will help to reduce the overall cost of medical care.
I agree. It is the cheapest form of health care that you can buy or that Medicare can buy. And what's really ironic, and I mentioned this on another show, we've actually had most patients are very welcoming of our help. I've had some patients that say, I don't want you to come out here. I don't really need you that bad because I don't want you to soak the Medicare system. I don't want to deplete the Medicare system of their funds. Who am I to deplete the Medicare system? And we try to educate them and say, you've been putting into the Medicare system your whole life. You have this benefit now. It's an insurance benefit. And if you would only access this insurance benefit and let home health come help you, whether it be skilled nursing or physical therapy or another discipline, you might be using Medicare's money, but you're using this much in comparison to this much that you might use later when you get sicker and require a hospital stay. So it's actually kind of counter to what some people think. But most people are thrilled when they find out the home health benefit because they don't know about it. And in fact, the other point I want to make, which I've made before, but I can't stress it enough, in home health, it's the only venue under Medicare, if you qualify, that you can get where there's no copay, no deductible, zero out-of-pocket expense, zero. That's not a gimmick. That's the same for any Medicare patient that qualifies for home health across the United States, regardless of what skilled home health agency you use. That's unheard of.
It's like the old Boy Scout motto, be prepared.
Yep.
Yes.
Absolutely.
And what's the other one? An ounce of umpteen is worth
an ounce of prevention is worth a pound of cure.
That's it.
Yeah.
Yeah.
But, you know, so many people thought when we passed the Older American Act in 1965 that President Johnson had performed a great big boondoggle on the American people. But I think over the years we've come to realize that some of these systems we've put in place are wonderful. They help a lot of people, and they just need to be used correctly.
Yes.
But they need to be used.
Yes.
And you said 4 or 5 things today, Nancy, that really ring a bell for me because I've done so many shows with social workers, and I've asked them questions about reporting abuse or reporting self-abuse, where you self-neglect yourself as you get older, and you just neglect yourself, and in the long run, the whole system pays for
a lot of times that is dementia related, by the way.
It's what?
Dementia, related to dementia. People
Yes.
that have dementia and they're in that mode where they're not totally demented in that they can take care of themselves, but they're demented enough not to see what's good for them.
What they need to do to take care of themselves.
And I am finding that as our population ages, I'm getting more questions from people that want to know how to correct a situation or how to report it. And I think that we need to figure out ways to...
I do have a resource before we wrap up for people. And I want to give everybody out there a phone number. It's 1-800-96-ABUSE, A-B-U-S-E. That's 1-800-96-ABUSE. And that is the state toll-free hotline to report abuse, suspected, you don't have to prove it, suspected abuse, neglect, exploitation of an elderly, disabled person or child.
Yeah, and that's good advice. We're out of time, and I want to thank you both for this show because I, frankly, have been doing elder care for 18 years. I learned a lot today myself. I just want you to know that. And I want to thank you, viewers, for watching today's episode of Focus on Seniors. If you have questions or comments, please call radio station WMEL AM 1300 at 321-631-1300. For more information on senior care and resources, visit our website, helpingseniorsofbrevard.com. Thank you for watching today's show, and I hope that you have learned as much as I have. Thank you.